Hello, my name is Darlene Black. I have chosen to speak on bipolar disorder. Bipolar disorder is also known as manic depression. It is known for the periods of behavior that can last for up to 2 weeks, the manic phase in which the patient experiences euphoria, high energy, inability to sleep, and impulsivity then changes to the depressive stage, which can be severe crying and a negative outlook in life. Bipolar disorder affects about 60 million people in the world, and science is actively looking into find a way to diagnose persons earlier and treat better and more quickly. Significant changes are also seen now on MRI reviews, and persons with bipolar disorder have a high incidence of addiction and either drugs or alcohol in order to manage their internal pain. Bipolar disorder also has an inordinately high suicide rate. This is a difficult disorder to diagnose, as the individual is struggling between euphoria and depression and may only seek help in one episode or the other. The physician may not see the full picture of the individual for some time, and therefore there can be a misdiagnosis or a missed diagnosis. The stress on the body is immense, resulting in hypertension, heart disease, and a plethora of other illnesses related to stress, and the high risk of suicide cannot be forgotten. Predisposing factors. Genetics is definitely one. The genetics plays a relatively accurate display of other related illnesses such as ADHD, and one family member may have bipolar and the other has ADHD or depression. Stress can be stressful situations and life events, and when stress is cumulative, many stressful events occur within a relatively short time, and the individual does not have time to process the feelings. This stress can lead to negative consequences that stick around for a long time. Traumatic events can be natural disasters, war, childhood abuse, loss of family, and lack of support during childhood. The anatomy and physiology of the brain. The brain is affected in the gray matter of the frontal lobe, the temporal lobe, the parietal lobe, and both hemispheres of the hippocampus. How bipolar affects the anatomy and physiology is very interesting. The prefrontal cortex of the brain is affected by bipolar. This part of the brain plays an important role in mood-related disorders and is responsible for cognitive control, impulsivity, and attention. The limbic regulation in the bipolar patient occurs in the prefrontal region. The largest effect is related to speech, facial recognition, and emotional regulation. The gray matter aids in the control of memory, movement, and emotions. Its processes inform the brain. Bipolar touches all that the patient knows and feels. Stephen Strakowski concluded that bipolar was characterized by reduced connectivity due to abnormal pruning or development in the prefrontal, striatal, pallidal, thalamic limbic network, leading to the dysregulated emotional responses. This model was supported by a number of common neuroimaging findings. In bipolar depression, there's also an increased striatal dopamine transporter level. In Stephen Strakowski's book, Major Depressive Disorder, he indicated that bipolar is one of the most common and disabling conditions affecting humankind. The illness is complex and dynamic, and many are misdiagnosed. Current MRI studies have shown changes in the brain of the bipolar patient. The MRIs showed differences in the brain regions that control inhibition and emotion, the frontal and temporal lobes. Further studies are being done by scientists around the world and indicate that the earlier this diagnosis is made, the better for the patient. Bipolar affects about 60 million individuals worldwide, according to the World Health Organization. The patient profile that we have is a 49-year-old female of German descent. She lives in Regina, living in her family home. She has chronic bipolar disorder. She is also obese, but has a family that is very supportive. This patient was a working woman, active in caring for her family and their activities. She had 2 young children and made a move to a new house during her 3rd pregnancy. Then there were 2 family deaths within 3 weeks of each other. The baby was born, and a 3rd death of a family member died 3 months after the birth of her child. Yes, stress is cumulative and can trigger an illness, in this case bipolar disorder. The patient is currently on valproic acid 500 mg BID and is functioning well now. The nursing process, I would ask her a few questions. What do you find the most challenging in managing your diagnosis of bipolar? Giving her time to reflect, I would let her answer, and then I would ask her, how is that working for you? Both of those questions have therapeutic communication skill. The first one is acceptance of her and her illness, and the second one is reflection, to give her time to think of what she has said. Nursing process. The NANDA priorities for this psychobiological disorder, I would prioritize the risk diagnosis and the health promotion diagnosis. The risk diagnosis would be to teach the patient the importance of remaining on the medication as dispensed by the physician, and the health promotion to be mindful of self-care and promote healthy lifestyle choices, such as exercise, deep breathing, yoga, and so on. Treatment goals. The goal for the risk management would be to have the patient recognize the need for regular medication despite the side effects. Side effects can be discussed with the caregiver, and changes should only be made on their suggestion. Side effects of medication are usually adjusted to, and the results of the medication do not occur immediately, but can occur over time, sometimes as long as a year. Healthy lifestyle choices would be to encourage the patient to begin an exercise program. Other stress-relieving alternatives are deep breathing, stretching, and reading to relax. The more routine in this individual's life, the more regulated her body can be. Regular sleep pattern, exercise outdoors if possible, and spend time with the people that she cares for and loves. Nursing intervention. Risk intervention would be to suggest a healthy diet to coincide with the exercise program. Healthy lifestyle is to encourage enhanced family processes. Examples of health promotion are readiness for enhanced spiritual, family, parenting, health literacy, and exercise management. The evaluation would be the patient begin to consider what it means to develop healthy lifestyle and will have started a walking program. The patient will understand her place in work and in the family setting. Patient profile considerations for care plan. The patient was working prior to this critical phase of the bipolar illness. With the stability that the medication, family support, and exercise, the patient can make preparations for start to return to work program on a gradual basis. So she is able to learn how to manage her time, adjustment to medication, and incorporate herself back into her family and community. Pharmaceuticals. Medications for bipolar disorder are mood stabilizers. Pharmaceuticals with bipolar patients is a matter of teaching and choice of the individual. There is a resistance to being consistent with the medication regime, partly due to the length of time before the results of the medication are felt by the patient, which can be up to 1 year, and the side effects of the medication itself. Lithium has been used for over 70 years and is effective in controlling mood swings. It is recommended as a first-line treatment for maintenance therapy. However, it can cause tremors, dry mouth, and some patients find it too difficult to tolerate. Thus, they stop their medication and bipolar symptoms return. Valproic acid is an anticonvulsant and manages the manic phase of the bipolar patient and has less side effects for the patient. It does not manage the depressive side of the illness, but that can be managed with other medications or a process of managing depression in different ways. A lot of patients miss the high of the manic phase and stop their medication due to that reason. It takes a lot of restarting to get the patient to the point where they can continue to use a treatment program and make the choice to return and stay on the medication. Patient teaching. We provide education with regards to the use of medication and their side effects. Drug information can be provided from the pharmacist, and patients should be warned to watch for signs and triggers of their illness. Discuss the behaviors that they find challenging, and they should be open about having bipolar disorder and make plans for episodes they need to look after themselves. Patient teaching should be managed in a very sensitive way. The patient is just beginning on a new journey. An appointment with a counselor and her physician prior to discharge will take some of the fear of managing this illness and leaving the hospital environment. She will feel there is help, and she won't feel alone, knowing someone will see her soon. Arrangements could be made for a home visit or phone calls. Patient education can help providers inform and remind patients of the proper ways to self-manage care and avoid non-essential readmissions. Better education can also help patients understand the care setting most appropriate for their condition and avoid unnecessary trips to hospital. Patient resources. In Regina, we have many community support resources. We have the Mental Health Clinic on Hamilton Street. We have Canadian Mental Health Association in Regina. We have Healthline at 811, and we have Wellness Together Canada. 811 is free. It is available in English with translation available in over 100 languages. For crisis intervention, we have the inpatient mental health services at the Regina General Hospital, and we also have mobile crisis services. These are non-profit, community-based organizations, and the services are provided on a 24-hour, 7-day-a-week basis in order to ensure accessibility regardless of the time of day. Thank you for listening to my slide presentation. Thank you.